Good afternoon, everyone, and welcome to yet another episode of our talk show series, Guide to Good Gut Health, brought to you by IHW Council and powered by JB Chemicals and Pharmaceuticals. I'm your host, Resham. So, today we'll be addressing a very vital issue which many parents face: what to do when your child has acid reflux. To shed some light on this particular issue and provide practical advice, we are joined by Dr. R. Bhanu Vikraman Pillai, a renowned consultant pediatric gastroenterologist from Amrita Hospital, Kerala. His expertise will guide us through understanding as well as managing this common yet challenging conditions in children around the world. So, without further ado, let's dive into an informative session on pediatric acid reflux. Firstly, welcome to the session, Doctor.
Good afternoon. Thank you.
Okay, so I think without further ado, it's time to jump into the questions. So my first question to you is, Dr. Pillai, could you start by explaining what GERD is and how it uniquely affects children compared by adults?
Sure. One thing we also have to remember, GERD, and there is a big difference between GER, which is gastroesophageal reflux, and gastroesophageal reflux disease. It's a common mistake. People put the word GERD or GERD, even though it may be just only GER. Because as human beings, all of us regurgitate to some extent. That is all right. But if that number of episodes of regurgitation from the stomach into the esophagus is beyond that normal number, beyond that normal limit, or if that reflux is staying in the esophagus for a long time, it is going to cause damage because of the acid that came into the esophagus, causing esophagitis, and its complications. At the same time, suppose the reflux happened and it's coming all the way into the throat, and it is coming into the airway, into the larynx or the lungs. It can cause, in small infants like a 2-month-old or 3-month-old baby, it can cause what we call apnea, and it can cause respiratory symptoms, and it can cause all other host of issues. So if it happens, if the number of episodes is beyond the normal limit, or if it's reaching unwanted locations, or if it's causing complications of the GER, that is considered to be GERD or GERD. So it's a big difference between GER and GERD. So one common, important example I can tell you is, it's very common as mothers, people may see like a 3-month-old baby, very happy, but right after feeding, the baby will spit up a little bit, but then put the word GERD. But that is not GERD. That baby is thriving well, gaining weight well, baby is otherwise beautifully happy, and there is no issues. That is called physiological GER or GER of infancy. That is usually does not cause any problems, and usually the infants will outgrow that and doesn't cause any complications of it. So that's a big difference between the two. So those patients does not need any pharmacology or any medicines for those babies. So that is not GERD. But only if it has happened in GERD, of course, that patients will require medications to help, and also non-pharmacological measures also to help them.
Okay. So, Doctor, I think the way you stated the difference is something that the parents are really going to know a lot from. So, my next question to you is, that's very basic, but something that the parents really want to know is, what symptoms of GERD, GERD, should parents be particularly vigilant about in their children?
Okay. The symptoms of GER or GERD, for that matter, the most common symptom in a child is vomiting or regurgitation. That's the most common symptom. But at the same time, if it's an infant or a 6-month-old or a 1-year-old kid, in addition to the regurgitation, they may have, suppose it is causing GERD, they may have irritability, they may have feeding refusal. So suppose the mother is trying to feed the kid, at the same time, the baby is turning the head away from the mother or the bottle. So because it is causing them to feel, if I suck at the bottle, I am going to feel the pain, so I don't want to suck. So it's called learned feeding aversion to the feeding. So that's an important thing that they will come with. Also, if it is causing failure to thrive or not gaining weight, suppose this vomiting is associated not gaining weight, Or if it's causing some bleeding, suppose the reflux is happening too often, too frequent, it is going to cause damage in the esophagus. It can cause esophagitis and causes bleeding. Those patients definitely require further assessment and treatment for these patients. Older kids, they usually come in addition to regurgitation. They may, just like the adults, they may say heartburn or burning in the chest, or water brush or feeding of regurgitation, like heartburn feeling. So that kind of symptom they can come with. So those patients are a little different, just like adults. But infants are the one that is a little difficult because they cannot verbalize what they are, what the symptoms are. In addition to this, they can come with abdominal pain, irritability, blood in the stool, hematemesis or blood, vomiting blood, feeding difficulties, choking on feeding. That's an important symptom they come with, because if the reflux happens long term, it can cause stricture or narrowing in the esophagus, causing difficulty to swallow. And child cannot swallow. They can come with dysphagia or impaction of food. They can come with all those symptoms they can come with. So these are all important symptoms they come with. But one thing you have to remember, the vomiting that happens in children, or the regurgitation, that may put the word regurgitation, but parents may not know the difference between the two, because they are both coming out, milk coming out from the mouth. So it is vomiting or regurgitation, either way it's same. But that is never greenish. So greenish vomiting is always a problem. That is not GER. That is something clearly pathological or a definitely harmful cause behind it that need to be worked up. Or if there's any blood in the vomiting, that also immediately need to work up. Or if the vomiting is associated with fever, or the child's head is getting bigger and bigger. So if there's a pressure building up in the brain, that also can cause vomiting, or hydrocephalus, or intracranial tumor. They can cause vomiting. So vomiting is not just reflux, or that is of course a very common presentation, but other conditions need to be considered. So if they have any of the other symptoms along with it, you must see the doctor for further workup and evaluate for that.
Okay, so it's important to know all the symptoms like you stated, and just not vomiting.
Correct.
So, doctor, with that, what is like how common is GERD in children, and at what ages is it most frequently diagnosed?
Yes. So in infants, let me put young infant, like a 4-month-old or 3-month-old baby, almost 50% of the babies will regurgitate. That's very common. And the majority of that group is what I called earlier, the physiological GER or the GER, that usually the babies outgrow. Most of the babies after about 4 to 6 months, the number of regurgitation gradually gets less and less and less. And close to 1 year of age, it becomes very infrequent. And by 12 to 18 months, they usually outgrow completely that symptom. So only with the time that you will know. But if the baby is just regurgitating, but the baby is otherwise thriving well, gaining weight, no other complications as I mentioned, and if the baby is not having any other irritability or any of those things, we can certainly watch the baby and see and how things go. And in an older kid, for example, adolescent, so almost 10% of the patients may have GER. Yes, it is commonly overdiagnosed, because as I told earlier, people have to differentiate plain GER versus GERD. Unless we pay special attention to the difference between the two, some amount of regurgitation happens that also could be labeled as GERD. That is not necessarily GERD.
Okay. Okay. So with that, what are the potential risk or complication that can arise if the GERD is not potentially or, effectively managed in the children?
There are definitely a few complications that can happen. Number one, so as I told earlier, with the pathological reflux, if it's regurgitated very often, or say normally physiologically as human beings, nature has a lot of protective mechanisms for us. Number one, if the regurgitation, the lower end of the esophagus, there's a circular muscle that prevent the regurgitation. So it helps. That is called lower esophageal sphincter. That helps to decrease the amount of regurgitation that happens. Number one, protective mechanism. Number two, if it happens, again, nature has a protective way, basically say gravity. So we are sitting up, except in an infant who is lying down all the time, that babies are more prone to get GERD because they are lying down all the time. But an older kid or an adult, even the happens, gravity helps to drain that acid from the esophagus back into the stomach. Also, the inside the esophagus, we all have mucus producing glands. That mucus can neutralize much of the acid. And also the saliva that we have in our mouth, that we constantly swallow. The saliva is alkaline. That also helps to neutralize that acid that it can get into the stomach. So all is a protective mechanism. And also the lining of the esophagus, that's a very integral mechanism. So it helps to prevent any damage to the lining. But if the integrity is lost because of constant regurgitation or long-standing or staying there long time, that kind of thing, if it is happening, that can disrupt the mucosa. It can cause esophagitis or erosions. The damage, the lining can get burned out. Just like you fall down on the stone or on the rock, our knees get abrasion. So similar to that, the lining in the esophagus can get broken down, and it can even cause ulcers. And if it's not treated long term, it can cause even predisposed to even cancer. So there's something called Barrett's esophagus, which is a pre-cancerous condition that also can happen even in children. That is very uncommon, remember, but it can happen even in a child. The Barrett's esophagus, which is pre-cancerous, that can happen in a child. And also, if this reflux is not controlled, it can cause stricture. So as I mentioned earlier, the food that goes into the esophagus, the tube is a tube. If the food is coming, the damage is there, that can cause a stricture or narrowing. The feeding cannot go down. Food can get stuck there. These are all potential complications. So if the ulcers or erosions happen, of course it can cause bleeding, and which can make child to get anemic and also may vomit blood. So all those things can happen in a potential if you don't treat it appropriately. In addition to this, one more thing I need to mention is as a potential complication. So this reflux is not only affecting the GI tract, like the esophagus. At the same time, it can cause erosion, the dental, our teeth, the enamel, which is the strongest material on the human body, stronger than even the bones. So the dental enamel can get erosions or damage on the enamel, because acid can gradually carve the enamel. So then the enamel damage can happen. Also, if at the throat, if it spills into the lungs, it can cause pneumonias, multiple frequent pneumonias. Yes, that is so common in a child who is neurologically handicapped and also lying down all the time. For example, a 3-year-old or 4-year-old child with cerebral palsy, they are neurologically debilitated kids. They cannot sit up, they cannot walk, they are lying down all the time. So the regurgitation happens, and that can come into the throat, it can spill into the lungs, it can cause aspiration pneumonia, frequent pneumonias they can get. And even a normal child or a normal walking around child, it can increase the risk of reactive airways disease or asthma. So these are all potential, and chronic cough and our voice change, hoarseness of voice. These are all potential complications that can happen in long-standing reflux if it is not treated appropriately and on time.
Okay, so I think you have really nicely stated the potential complication or the risk that can happen, and our viewers, whosoever is watching, they can learn a lot from this particular answer for sure. So this is something that I personally want to ask you, is that doctor, in your experience, are there any environmental factors that can trigger the GERD in children? And if you could state some examples as well.
Yes, say most of our human diseases is a nature and nurture. So nature, genetics. So for example, nature, I know that is not your question, but just may mention 2 sentences about it. Nature, for example, hiatal hernia. So hiatal hernia is in the lower end of the esophagus, is not closing tightly. It is, remaining, it's like a sac. It is coming up, easily coming up. That can predispose to increased reflux. That is very common in a genetically predisposed person. In Indian population, that is less common, but again, Caucasians, white people, is very common. Smokers, obesity, they are all notoriously common to develop hiatal hernia. And also patients who have, for example, scoliosis, this vertebral, column, curve, wrong curve, that can increase, and lying down patients, muscular, for example, developmental delay patients or muscular, always dystonic or spastic patients, they are all very, very prone to develop hiatal hernia. So that is one thing that can increase it. Coming to the environmental factors, the most important thing is, one of them is smoking. So smoking in children most of the time it is not active smoking, even though some teenagers may get exposed to smoking by themselves, but majority are passive smoking. Even passive smoking can increase the risk of reflux. Okay, so that is a very, very important thing to remember. So in adolescence, so if it's a smaller child, we tell the parents, make sure there is nobody in the family who is smoking. So when I mean family, it is not just the blood relatives, talk about anybody who is looking after the baby. That is all considered family, because if I smoke and take a baby after that, the smoke, then you got effect is coming out of my breath and is damaging that baby. So it can cause problem for that, that. So it's very, very important to make sure there is no exposure to cigarette, not only inside the family, not anybody who is encountering the baby, anybody who is touching the baby, anybody who is coming in contact with the baby, they should not smoke or get exposed to cigarette smoke. That's number one. Number two, in the environmental factor is obesity. See, if the person is obese, that is a very important risk factor for GERD. So it's very important that sometimes we can help with it. Sometimes it's beyond our control. Some of them it's because some of the vomiting is not because their creation. It is happening to themselves for other reason, which is beyond the parents' control or patient's control. Understand that. But it's something, the obesity or overweight is definitely something that increases the risk of GERD. So smoking and obesity and alcohol intake. Alcohol intake, yes, it's an environmental factor because it can increase it. And those dietary habits. If you eat a lot of spicy food, so spicy food, carbonated drinks, so like Coca-Cola, Pepsi, Sprite, 7-Up, Mountain Dew, all those carbonated and caffeinated drinks, they both increase the number of reflux. So carbonation, because as a human being, if you drink it, after a few minutes you burp. Along with the burping, it acid from the stomach also come into the esophagus. At the same time, the pH or the acidity of that drink that you take is very, very acidic. Directly, that is causing a problem. So it's both ways. The third thing is, and so when you drink that, the stomach gets bloated because of the carbonation. So that easily regurgitate. And along with that, the carbonated drinks, caffeinated drink. Caffeinated, the problem is caffeine relaxes the sphincter. So when you relax the lower sphincter, that easily regurgitate. Also, caffeine stimulate the acid production. So it's a double whammy. So in two ways it is hurting the person. So it causes a problem. And also lying down right after a meal is extremely crucial. Don't lie down for 2 hours. As in an adult, sometimes I recommend up to 3 hours right after a meal. Don't lie down. So if you lie down flat, so the stomach that is full regurgitate into the esophagus, and along with the food that comes up, this acid from the stomach invariably will come up. That is going to cause damage in the esophagus. So all these are very, very important factors that we have to remember. And in an infant, it's extremely important the parents or the caregiver to make sure they don't overfeed the child. If you overfeed the child, the intra-abdominal pressure goes up. So easily that regurgitate. So anytime when the regurgitation happens, the acid from the stomach also regurgitate. So it is not just for the feeding that is coming up, the acid also come up. So it's very important to remember that we, avoid these things also.
Yes, surely, as you rightly pointed out, that we should avoid these points. Especially people think that if you're smoking, then it just affects your lungs or your heart, but it affects your gut health as well.
Correct.
Yes.
Correct.
So, doctor, what is the standard treatment prescribed for children with GERD?
How I approach, and most of the recommendations, what they do, there are twofold. One is non-pharmacological measures. So without medication, what all things they can do? As we just mentioned about the environmental factors we're talking about, all these factors has to be recommended to the family to avoid those things and follow a healthy lifestyle. So don't lie down right after a meal, avoid spicy or carbonated drinks, avoid caffeinated drinks. All those things are extremely important. Don't lie down after a meal. So it's a very, very, and also, and a child is another important factor I forgot to mention is ketchup. Tomato ketchup is notoriously increased the reflux. It is acidic. At the same time, it relaxes the sphincter. It increases the reflux very commonly and very importantly. So it's very important. That's why many people who eat after pizza and everything, it has got tomato sauce in it. that get the heartburn feeling, because the tomato ketchup is the culprit. So the tomato sauce notoriously increases the reflux. It's very, very important. So and all these non-pharmacological measures is very important to be dealt with. One more thing in the non-pharmacological thing we have to remember is, in an infant, one of the common presentations or that mimic GER or GERD is cow's milk protein intolerance. So it's cow's milk protein allergy. So babies who have milk protein allergy also present with extremely exactly similar symptoms: vomiting, irritability, feeding refusal, fussiness. All those things come exactly like that presentation. So that's the same age, a 3-month-old, 4-month. That's a typical age for a baby with a cow's milk protein allergy also start manifesting. So that is a very important differential diagnosis one you have to think of. So if you suspect that's the age group of the baby, and you can, one thing you can do is avoid the milk protein in the baby's diet. If it's a cow's milk, is a formula fed baby, give a formula that is hydrolyzed, pre-digested, that so the immune system does not recognize it as a full antigen, and the baby outgrow it and get better. That is one thing. Second thing is, if the baby is breastfed baby, they can still get it. And in that situation, the mother gets the treatment. Mother has to avoid all the things that contains the milk. It is not just the milk. Milk and all milk products, the laddu, jalebi, ghee, yogurt, buttermilk, all those things they have to avoid, not just, and biscuits, because there are a small amount of milk in it. So all those things you have to avoid it, and continue to breastfeed the baby. Don't stop the breast milk. Continue to breastfeed that. Usually within 4 to 5 days, you will see a remarkably different baby. You will see that. And so one thing to remember, if that mother is doing that, you always have to advise the mother to make sure she get 1 gram calcium. That means 2 calcium tablets every day for the mother to help to maintain the nutritional status for the mother. So it's very, very important. We have to look after the mother also. If you advise something like that, it's your job to make sure advise the mother to keep her health appropriate, taking the calcium tablets in the maternal diet. And so that's the non-pharmacological measures. The pharmacological measures, there are 2 things, there are several things you can do. One is acid suppression. Acid suppression has an important role in controlling the GERD symptoms. If the symptoms are mild or occasional or infrequent, it's extremely appropriate to give, I think I am faint in the grainy. So I hope, can you hear me?
Yes, Dr. V.
Okay. Can I go ahead or should I leave and come back in?
I think you can go ahead, and then we'll just see for like.
Yeah. So same thing happened a few minutes ago too. So, and if it doesn't come up, I can log out and come back too. So, but let me see. I don't know, but we lose that 2 minutes. That's the only reason. Okay. So if it's an occasional symptoms, mild symptoms, one easy way to do it is S2 receptor antagonist. So that is, S2 receptor, histamine 2 receptor agonist, like ranitidine, famotidine, nisotidine. There are multiple drugs that is available. That's appropriate. They can take an as needed basis. If it's only occasional symptoms, they can take it. That's appropriate. There's nothing wrong in that, because that helps to control that. For example, the person is doing okay. If they get symptoms only when they go for a party outside, taking a dose of ranitidine is appropriate for that situation. That's appropriate. There's nothing wrong in that. But if the symptoms are too frequent, or if it is causing severe damage in the esophagus, for example, suppose you did an endoscopy and found there is erosive esophagitis and damage, in that situation, it is appropriate to give a proton pump inhibitor. Now it's coming up. So the proton pump inhibitors are effective drugs, but the problem is, do not take it lightly, because there are potential side effects on the proton pump inhibitors too. They are good drugs. There's nothing, outright wrong with it. They're effective drugs. At the same time, one should use it only on, what is really indicated. When it's appropriate or indicated, only then you use it. That's the most important thing to remember. So when you give a PPI, so the S2 blockers, as I told you, you can take it daily. That's okay. or you can take it on as needed basis. When they get symptoms, you can take it. It works within few minutes. It can be helpful. That's appropriate. So that's very appropriate. But the proton pump inhibitors, when you suppose there is erosive damage or esophagitis, things like that, in that situation, it's appropriate to give a PPI, and that's the way you have to take it consistently until the lesion heals, not as needed basis. The PPI doesn't work on an as needed basis because it takes the full benefit. For example, suppose you or I, suppose we have a problem with the reflux and you're going to start it, the full benefit get in our body for 3 to 5 days later. The full benefit. It can start working, but the full benefit takes 3 to 5 days to get it. Okay, so it doesn't give the full benefit immediately, so that's a problem. But in somebody who has severe damage, it's appropriate to give the PPI and take it correctly 30 minutes before the food. That's very important to take the PPI on empty stomach. So if you take it after food, a good part of the medicine gets lost without absorption. So take it on an empty stomach, and you must eat 30 minutes later for the medicine to work effectively. Okay, so that is acid suppression is one way to do. The other thing that you can do is something called motility agents. Unfortunately, we do not have any effective motility agents. There are a few drugs that we use. One of them is domperidone. The problem is it is 50-50. Over 50% patients, it may help. 50% it does not help. But suppose the patient is having vomiting too many times, the mother is so anxious about it, it's appropriate to give for a week and see whether they help the baby. If it's helping, sure, you can continue for a few weeks and see how the baby does. That's appropriate. But so domperidone, metoclopramide, they are very similar family of medications, but there are potential side effects. It can get neurological side effects too, dystonia, all those things can get it. So it's important that you take it only when it's absolutely necessary. Again, that has to be given before the food 3 times a day, because every time before the food you have to take it to be you giving some benefit. So that's appropriate, one thing to do. There are some other medications also you can use it, but less studied. But baclofen is one, so that may be appropriate. So there are certain medications you can do, but avoid overeating, avoiding all those things, as I mentioned earlier, non-pharmacological. They're very important. It can help just like medicines too. So that's how it goes. If the medicine did not heal the damage, then we have to think about surgical option. So that is one thing we have to keep in mind as a background. If the medicine fails, something to do. And if you give a PPI, so suppose I have erosive esophagitis, I take it for 8 to 10 weeks or 8 to 12 weeks. Usually that erosions heal, and once it heals, you can gradually wean off the medicine. Do not give forever and ever the PPI. The only certain indications you give PPI for a long term. Otherwise, once it is over, you gradually try to wean off the PPI.
Okay. So, like you rightly pointed, is better than cure. Avoid ketchup, don't go for smoking. And then if the situation is quite extreme, then we can go for medications, but not before that, right?
Correct. Exactly right. I mean, medication you can give, but you can give concomitantly the non-pharmacological measures. You can do both at the same time too. Suppose the patient has erosive esophagitis, you don't have to wait for the non-pharmacological measures alone. You can institute both the non-pharmacological measures and medications at the same time, on the same day. There's nothing wrong in that. But you have to institute both for that to get the full benefit or for the disease.
Okay. So, doctor, could you also tell us what role do probiotics or dietary supplements play in the treatment of pediatric GERD?
Yeah. So, probiotics, there are some studies showing certain probiotics have been helpful. One is Lactobacillus reuteri is one of them. So it helps to decrease the amount of regurgitation, and also it also increases the gastric emptying. So the stomach empties a little faster. So when the stomach does not empty fast, so when there's a delayed gastric emptying, the regurgitation happens more. So both ways there is benefit. And in addition to that, the painful feeling or the discomfort, irritability, all those things also there is a benefit with the probiotics. So it is appropriate for a probiotic to try, but that alone may not be enough to treat, but it's very appropriate to try. Yes.
Okay. So, doctor, what would you recommend as the first steps for parents following a GERD diagnosis in their child? The first steps.
First steps, as I told, non-pharmacological measures are the number one. If it's an infant, avoid overfeeding. If the teenager, older kid, avoid overeating. And avoid, it's older kid, avoid carbonated drinks, caffeinated drinks, avoid exposure to smoke for both the categories. And avoid ketchup, avoid fried things, so spicy things. All those things are very, very important in additional medication. So non-pharmacological measures are very crucial in additional medication to take it. And once you prescribe a medication, it's important they take a medication correctly and regularly if you need it. So if you take it regularly, make sure you take it before food, 20-30 minutes before the food. Make sure they eat 20-30 minutes later for the medicine to get the full benefit. And don't sleep right away, or not even sleeping. Don't lie down right away right after meals. All those things are extremely important. Doing some exercise to prevent getting overweight. All those things are important.
Okay. So, what has been the most challenging aspect of treating the GERD in your experience? Could you share something that you've tackled recently?
Yeah.
Most
So
challenging part.
one other thing is the dietary habits is one of the important things. Say it's important the child eats what is made at home. If they make fried things at home, you can tell the child not to eat it. That's not going to happen. The child is going to eat because the mother is eating, or father is eating, or the older brother is eating, a sister is eating. So the whole family has to change their lifestyle. So
Hmm.
that's an important thing. Second thing is smoking. It is not the child who is smoking. At the same time, most of the time, the child is not the one smoking. The parents or the caregiver or the babysitter. So
Hmm.
make sure they are avoiding or following your advice to get the benefit for the kids. So it's very important, and also giving time for the medicine to work. So that's very important because they see, as a human being, everybody wants instant fix. That
Hmm.
usually it doesn't happen with that. And many times, for example, when you give a medicine, it takes a few days to start working. So you have to give time for the medicine to work. So these are all very important. And you tell upfront what is the expected duration, what's the expected time the medicine start working. So what's the expected lifestyle changes that you have to make. And the whole family has to do it. And also if the child is overweight, it's very likely the mother and father or somebody else is also overweight in the family. So they also have to change their behavior in front of the child, so child also understand I can do it. So
Yeah.
it's very important. It's a team effort. It's not that just the child and the doctor and the child alone. The whole family has to change their lifestyle behavior to get the benefit out of it.
Yeah. So, like you pointed out, we have to wait for the medicine to work, something that
Yes,
we do not do as, the parents and, the
correct,
patient. Yes, that
correct.
is rightly pointed out. So, finally, do you believe that lifestyle changes made during childhood for managing GERD can lead to long-term health benefits as children grow into adults?
Yes. For example, the overweight child. So suppose the child is overweight or obese, and if that child change their lifestyle, become healthy weight, and follow their lifestyle changes that you advised, it's very likely that child will remain a healthy weight, or maybe it's only slightly over the normal weight, and prevent getting over, obese, or so that change can last for a long term. And also, if the erosion's damage is healed, that can, if the child understand it, if that's going to come back and can make him Barrett's esophagus or a precancerous condition, if that's many of our children, they are intelligent children, so they are not dumb. But if you make them understand it, they are likely to follow that and avoiding carbonated drinks. So many children, if they, not because of force, suppose if they make the decision themselves and avoiding carbonated drinks, they are likely to follow that. They are likely to follow that behavior long term and even into adulthood. And that can help them to have a better health in the future too. Absolutely.
Yeah. So, like right now, you just pointed out that ketchup is like really bad for your health. I think now
Yes.
I'm going to definitely follow that for sure. So,
And
thank you, Dr. Pillai. Yeah.
people
Yeah.
people may not remember about the ketchup because they spoke about smoking or spice. Ketchup is notorious.
Yeah. Because smoking and everything, I think we all are aware about, but ketchup is something that we
Yeah.
hardly like know that
Yes.
fact. Yes.
That's okay. And
Okay.
I forgot to mention citrus fruit and citrus juice, the orange juice,
Okay.
musambi juice. So citric acid, because of citric acid in it. So that also need to avoid. Citrus fruit and citrus juice also need to be avoided.
Okay.
Okay.
So, thank you, Dr. Pillai, for joining us
Thank you. Thank you
today and
very much.
providing us such valuable insights. Thank you,
Thank
Doctor.
you very
Your
much.
expertise, yes, has offered like a very practical advice and reassurance to our viewers who have joined us, especially the parents facing such challenges. So, to our viewers, we hope this episode has been enlightening and help you navigate the challenges of managing your child's health with more confidence for sure. Join us next time on Guide to Good Gut Health as we continue to explore vital topics that impact our health and our daily lives. Thank you so much, everyone, for joining.
Thank you. Bye.